I'll keep going if you put your hand up. Oops. Hang on. Okay. Is that it? Yeah. So that were the divisions in New South Wales, and they formed Medicare locals. Now, if you don't like someone and you want to upset them, you use a name that they don't like. So the left of politics likes Medicare, so they called the locals Medicare locals. The right of politics hates Medicare, and they didn't like the title. The doctors didn't like Medicare locals because they were comfortable in the divisions which they control and own. I was on the board of a division as a community rep because my doctor is PhD public health, not medicine. And I was on the division of general practice. And when the government decided to increase the size of primary health care to the Medicare locals and change it to a broader perspective on primary health care, my board said to me, "You're very experienced in all this stuff, you can chair the working party that's going to set it up." And then I became the chair of the new Medicare local. So, big area. There were 3 divisions of general practice in that area. We amalgamated 3 different groups of people, 3 different cultures, because Tamworth has a large acute hospital and very good services. Out west, further out, they only have GPs, small hospitals, fly-in specialists. So, and the GPs do surgery and obstetrics out there, whereas in Tamworth, it goes to the specialists. So, different concept. Brought us together, we all loved each other, and we all worked hard to make the Medicare local work. So, that's the Medicare locals around Australia, about 60 odd around Australia. Our objectives were to improve the patient journey, try and integrate and coordinate care, identify health needs, identify gaps and implement strategies and primary health care initiatives, and continue to support general practice. General practice felt that their influence had been diminished and that other professions had a greater control of the system, and they also thought we were setting up services in competition with them. So after spending a year setting up a Medicare local, maybe 2 or 3 years, we had a change of government, and the new government said, we don't like Medicare locals, the doctors don't like them, we're getting rid of them. So again, I was asked to be on a steering committee for our Medicare local with 2 others to form a primary health network. Okay. So we now have, 1 year old now at this date, we now have primary health networks. And there's only about 30 across Australia, so they're much bigger. Our one, as you can see, in the centre there, I'll try and, there, that's the Hunter, New England, Central Coast primary health network. We've been going for a year. Again, getting bigger, but still considered to be local. And our job was to purchase, contract and commission services and support primary healthcare professionals, but not to deliver services. So we've become a funder and a commissioner. Okay? So that's a vast difference in 2 decades from being supportive of general practice to being a commissioner of services on behalf of government and trying to bring general practice into a system of primary health care. Okay, be part of the system, not standing outside it. So, our job is to reduce fragmentation of care, try and get different providers to work together, ensure that general practice is paramount, leverage and facilitate purchasing of services, and improving financial performance. So this year, for the first time, we put out ads, we called tenders, and we actually funded different service providers to deliver services. And we're on to our second round of doing it now. fairly complex, difficult area to work in, but we started. So, going back to public policy, there was no great pronouncement about how all this was going to work or how we should commission. They just set us up and told us to do it. Okay? Yep.
I'm Kamunat Moon Yim from Phnom National Institute of Health Workforce Development. Since we already know that health market is also the market failure already. But by the thing that you said in this slide, it said the primary health network only deliver service where there is a market failure. I just wonder what is the meaning of this failure. Thank you.
Well, this one here. If for some reason a service we funded failed, now that may be they didn't have the staff, they were poorly managed, it didn't work, for any reason. So it's a proviso in there that we're not allowed to allow services to collapse. So if there's a danger of collapse of someone we've contracted, we can move in, take over and run it until we can go back and find another provider. And one of the challenges in the rural areas are if you want to contract psychologists, say, to give mental health consultations to GP patients, there's only 1, 2, 3 psychologists in a town. So if the former Medicare local contracted and paid them, but we're not allowed to, we go out to tender, some other NGO or profit company will come in and they say, we'll deliver it. Then they go and contract the same 3 psychologists to deliver the same service we used to provide. So in a sense, you know, it's a bit like changing the deck chairs a bit in those circumstances. And also we've got to be careful we don't disillusion those 3 psychologists who can't move elsewhere because they can work anywhere. And we might save a bit of money, but we might lose a lot of goodwill. And the GP and the patients get confused. So bigger in a more dynamic urban setting where there's a lot of providers, a lot of services, more difficult in the country. And part of our charter is to make sure we develop and retain and improve health professionals. So we've got to balance off the getting the best price and the best quality with doing it sensibly and logically and retaining very scarce resources as well. So it's an important point. And we're doing it while we're learning how to do it, and the providers are doing it while they're learning how we think it should be done. And we're trying to engage them and the communities in the design of the way we do things. So we'll come to it. We've got 3 community councils, we've got 3 clinical councils, and all our proposals and concepts and models go through that discussion phase with them to make sure that they're happy and they think it'll work. So a lot of engagement, a lot of consultation coming to it. So that's my PHN, and as I say, it's probably a 10-hour drive. It's larger than England in geographic size, but about 1.4 million people spread out. Most of them live down on the coast, and the good people live up in the country. We're very, very much focused, as it was said by one of the earlier presenters, talkers, very much focused on innovation, research, designing and planning healthcare and support services. So we have a planning team. I chair a committee that looks after that aspect of innovation, research and service design. And we say to our staff, do not put a proposal up to the board for approval or for tick-off unless you can demonstrate evidence-based research and some process of evaluation and that the data that we have supports the priority of that service. So we're developing a culture of planning, research and innovation across all our staff and with the health professionals we work with, and I'll talk a bit more about that later. Again, our issues are the Aboriginal Health Program. In some part of our population, we've got 28% Aboriginal population and with poor outcomes. We've got to provide after-hours GP services, make sure they're there. We're at the moment calling tenders for mental health services to improve mental health care because it's a problem in Australia. We're trying to develop allied health services and their integration with primary health care and with general practice. And we're very much trying to improve health screening and immunisation so that we can have a better understanding of how we're improving cancer care and all sorts of services. So this is the same primary health network, 1.2 million people, very big area, a lot of local government, a lot of disadvantage, socio-economic determinants are a real important area that we need to address in healthcare. Traditional health services aren't going to fix those problems, and we really need to look for new solutions about working differently to improve the status of communities so that their healthcare can subsequently improve. So we've got a very large Aboriginal population and it's a very young population. We've got 1,300 GPs, which sounds a lot, but they all live in Newcastle on the beach and they don't live up where I live. And some areas have poor access to them. There's 31 public hospitals in that area run by the local health district. When we set up our organisation, we put the chief executive of the two health districts on our board, the primary health care board, to make sure that the health districts and the primary health care people work together. And a lot of aged care facilities, and again we're trying to keep older people out of hospital and well in the community. So this is where I get to Professor Oasi's mountain. Oh, sorry. Yeah.
Okay, yeah. I just wonder, would you please figure out the ratio between curative care and preventive care within the primary health network?
Right. Where the emphasis of our work is. Our emphasis is primary health care, not acute care, hospital care. But we know that there are people in the hospital that shouldn't be there. We know that our emergency departments are used as general practice and they shouldn't be, etc., etc. So part of our planning and our strategy is determining how we improve the model of care so that they don't go to hospital or they don't go to the emergency department. So we look at the acute care sector in terms of how can we prevent people from using it. So we don't deliver acute care services. Okay? So it's primary health. So our challenge is to keep people out of hospital, reduce the length of stay, or find alternative models of care in the community. So we would not be doing our job if we were worrying about acute care services. The acute care sector people, they like us because they're under pressure financially and with performance measures to not admit people to hospital, to reduce the length of stay, to prevent preventable and avoidable admissions. And they see us as helping them to meet that challenge, which is the same challenge as we've got from a different perspective. So they're forcing us both to work together closely, and we collaborate closely. We're planning closely together, but we do not deliver acute care, and they're looking for ways to reduce that down because they're facing cost pressures in their budget. Okay? Now, this Professor Oasi, I will come to it anyway, about his mountain and his triangle, really impressed me. I thought that was a great starting point for the discussion today about moving the mountain. Of course, the mountain is health reform. In our country, the elephant in the room is managing downward fiscal pressure. In other words, they want us to do more with less, and they want us to cut out things that have had no proven value. And that's what we've been tasked with. The government says you can't let health spending continue to increase faster than the GDP, because our budget, is stalling like a lot of countries now. We're not getting high growth, and we're getting lower growth. So we haven't got the increased income to pay for leaving things as they are, let alone doing more. We've got an imperfect market because people expect to get their health care for free, and so normal market pressures don't have limited influence. I've been following Obamacare in America because the American system's not a good example of saying, well, they're doing great things there. Most of their outcomes are pretty poor compared to ours. But I'm impressed by the fact of the social insurance approach, collaboration with providers, and defined populations where they're trying to get improved outcomes. So I think there's some potential lessons for all of us. I'm not saying it's great, but I'm just saying they seem to be doing some innovative things. But even in Obama country, there are questions being asked about what is the overhead of providing care in this way. And I think the lesson for us all, it doesn't matter whether it's a government service provided by Thailand or Australia, or whether we use private health insurance or the private sector or a social insurance thing like Obamacare, there are costs to delivery. And we're saying in our PHN, let's be careful, let's work out what our overheads, our costs are, and how much it's costing us to deliver services through this commissioning process. Because in a year or two's time, they'll be asking that question. Why should we keep you there? Prove you're doing an effective job. So the days of just getting the money and delivering the service without rigour, without a threat to our existence, I think are just about over in Australia. I think Australia's got a big financial problem coming up, and the government realises, but not too many other people. So we're trying to ensure we deliver the right mix of care for the chronically ill, the frail-aged, and allocate resources optimally. And that requires a more integrated system of healthcare. And I can't emphasise that more. The days of thinking so much about hospitals, and hospitals are important, or community health centres, or public health as entities alone are fast disappearing. They're all parts of a bigger system. They're all important. They all have different values and purposes, but in terms of managing and resourcing them, we need to try and make sure they work more effectively together, and we're using the right service at the right time. So, from our point of view, we're moving to try and analysing data. A lot of data is collected but never analysed, and we're looking at trying to understand what that data is telling us to better inform our practice. In fact, all those payments made to doctors for patients all over Australia go into a computer system that none of us have had access to tell us about utilisation in general practice. So we need better data, more of it, and better analysis of the data, and better questioning of the data. We're developing clinical pathways with our clinicians, working out the best way to treat people and where to refer people, so doctors in the rooms can press the button on the computer and say, for this type of patient, the best practice pathway says this is what you do, this is where you send them. Okay? So we're cutting out waste, duplication and poor referral pathways by trying to standardise it and put the data and the evidence there to support the doctors. We're investing in new models of care. I mentioned hospital in the home, health home, and we're starting up those pilots now. Population health is a significant thing. We've got those charts. I've got a one-page thing for each local government area in our region that sets out all the demographic, morbidity, mortality, socio-economic indicators for each local government area. Age, sex, distribution, and so we know by local government area what the issues and the priorities are, and we're finding that the problems are turning up in the same local government areas. So we're getting our hotspots and our areas where more attention needs to be given rather than just the general population. In fact, one of the issues I think we're going to have to talk about universal healthcare is equitable access to all, but there's an argument to say there are some who need greater access if we're going to get equitable health outcomes. So that's another debating point. And measurement of performances. We've got to look at new ways of delivering services, particularly for the poor and disadvantaged, because it's not the health system that's going to improve their health, it's better education, employment, and opportunities to engage and be part of the normal society that's going to allow them to improve their health outcomes. And of course the health insurance debate, harmonising services might save money, and how do we do that better? Regional funding. We're going to a great length to use social media to engage with professionals and the community to create change. I'm rushing a bit now because I've taken too long. So Professor Oasi's triangle talked about knowledge, social movement, political involvement and changing the system from an ill health orientated to a good health orientated system. That's basically what we're all trying to do. We need to develop very good health policy leaders to make that happen. We need to have a social movement, the social media and political involvement to make it work. And from where I come from, my background, we need health services that are geographically relevant and located near the people they serve, and to work across boundaries, across agencies, and have a view about accountability, trust and stewardship in the system. And the debate about whether it's centralised, decentralised, we covered. And the health managers need to be accessible to the communities and the health professionals that they're responsible for, the service they deliver. So, just go. So I won't go through all that, but I think they're fairly good principles for managing health systems. Right, and back in 2009 we had a conference at Nereswan where there were 500 people from 17 countries present, and we debated what was essential for good public policy and management of health services. I won't go through them, but you'll see in their management and leadership of health systems as being considered important. So that was something we've developed for our involvement in Thailand. These are the points that I think are important for a health leader and manager to be effective in their roles, and that's why we're setting up a College of Health Service Systems Management and hopefully training people to have those qualities and backgrounds. And that's it. And I'm sorry it's taken so long, but I was asked to talk about all that. Okay? Oh, and there's some of people you'll know at Tamworth Base Hospital, in an old part of the hospital, and that's when I used to look younger. But you can see that healthcare does age you, and it's now a modern 300-bed brand new hospital with cancer screening centre and very sophisticated level of services, and it serves that big region where people are, 3 or 4 hours away from it, so it's a very good facility. Okay, so hopefully that's been of help. I'm sorry it's taken so long, but all right. Thank you.
If we can to all professors. Any questions or any point that would like to discuss? I think we allow